what's changed in the new normal. And there's lots and lots of stuff being bandied around at the moment. And so what I wanted to do was make this very country specific for Ireland, so that it's exactly as is relevant for us. I'll give you a bit of background, but then bring it down to specifics. That's why we've got myself and Laura, the team that you know. We've got our research hygienist online, Svetlana, for any hard questions there as well. I'm going to talk about the impact of COVID on dentistry, because again, this is one of the things that has highlighted dentistry as an essential service. And it's really interesting because as dentists, most people tell us most of the time how much they hate us, and we are that kind of figure of fun and fear in the media or whatever. If I ever get asked to do a media radio thing, they always want somebody going in the distance, or with drills going. You know, the media really push dentistry up, but it's been shown, along with hairdressing, to be the thing that people have really, really missed and can't get around. So the first thing is, dentistry has been less, certainly what I want to say is that dentistry is still a relatively safe environment when things are done properly. And certainly in Ireland, that's the case. Now, you may hear all these new additional precautions that need to be taken for dentistry, but that's sometimes in countries where they didn't do what's called universal precautions. And in Ireland, that's law. That means we have to treat every person that comes through the door to a dental practice as if they're potentially carrying some kind of transmissible virus or bacteria, whether it's HIV, hepatitis. However, this is a big job. And those of you who spend time with us will realize that I spend a lot of my time sitting, tapping at a computer or whatever, but the person who runs what's called our universal precautions is Laura Parkinson, our dental nurse. So it's not only what happens in the dental surgery, it's what happens to make sure that the dental surgery is a safe place for everybody that comes in regardless. People don't need to disclose to us. We don't need a diagnosis up until now. So Laura, she's on here. Laura, just talk the guys through what generally would happen in a dental practice anyway, before it comes in. So what's
very first
routine?
Very first thing in the morning, I have to flush all the water lines. Can you hear me? Great. Stagnant water is the devil in dentistry. So we are only here Wednesday and Thursdays. So we have to flush them for 3 minutes.
We're losing your sound.
Here.
Okay.
So
guys, can you hear, or are we losing Laura's sound? Laura, can you hear us?
No, I just lost her there, I think.
Okay, she'll come back. Yeah.
You good?
Laura, do you want to bring your phone into the seminar room, maybe, or somewhere where you've got a better connection? So basically in the mornings there is a massive routine. Our big problem in dentistry has always been water lines. So this is one of the big things, because waterborne infection, because of all the water that we spray, because of all of the stuff that goes down the spittoons, our big area always is water lines. Do you want to try here and see if you're getting a better? Have a little look now. Okay.
Okay.
Let me just, I'm going to take a little, try that.
Can everybody hear me now?
Yeah.
Great.
Okay, I'm going to bring you onto here. Okay, let me just turn Bluetooth.
So we were back to, in the morning I'm damp dusting, we haven't been here.
Okay.
Okay, try again.
Come in here, Laura. Come in here, Laura. Can you hear me now?
Yeah,
Great.
turn that off, please.
Yeah.
Mute that.
Done.
There we go.
So for the setup, I have a particular set of things that have to, each unit has to be covered with plastic covering to make sure if there's any areas where there's gaps that can't be wiped, that they're covered pretty much as well. Set up with an aseptic technique so that everything's clean for you guys when we're starting off. And then when you're finished, when I remove the dirty instruments into the other room, I have lots of work to do then as well. So aside from wiping down the room, I have to also flush the water lines on the chair. Each lead has to be flushed for 30 seconds per lead, which is done manually. It's lovely. And that's to make sure that any water that may have been sucked back in through the handpiece or whatever isn't in the instrument for when the next person comes. At the moment, what's happening there is I have to take away all the dirty instruments, leave the room completely, and then wait a full hour before I can go back in. So it's kind of reducing the amount of people you can see.
Okay. Oh my God, we got it, Cathy. So in reality, there is a massive thing that we go through. I have to be aseptic. I have to make sure that we cannot transmit anybody from person to person. Because social distancing is absolutely impossible in dentistry. Lots of the specialties that are happening, people can wear masks. They can wear masks during a medical consult, but for dentistry, those masks have to come off. And up until now, we've been worried about blood-borne viruses. So loads of the things we use are absolutely single use, for example, makes dentistry extremely expensive because all of the cross-infection that needs to be undertaken, all of the procedures that need to be taken is one of the reasons why dentistry needs to be, is very expensive. Certainly after things like CJD, loads and loads of instruments had to become single use. So now there's always this great big thing in dentistry about environmental sustainability against single use instruments, because there's no doubt that medicine can be aseptic and should be. However, it's against the price of the environment. You know, what's the environmental cost of all that plastic everywhere, of all those chemicals that we have to use, strong chemicals with really difficult procedures. So dental nurses trained for 2 years, and a good part of that is on cross-infection techniques. So the first thing I want to say is ordinarily dentistry is a safe place to be. And had it not been like this, COVID-19 and dentistry had the possibility to be a nightmare for patients, because it could have been what's called a cluster. But we haven't seen anywhere in Ireland or Western Europe where a cluster of COVID infection has come to patients from dentistry. So at the outset, because of people like Laura and a team there, I think what I want to say is that people with bleeding disorders certainly don't need to worry about going to a dentist from a safety point of view. If you can get a dental appointment, then everything will be being taken care of, okay? The risk really has been the cost of all of this additional equipment that's used for COVID. Because lots of practices have had to use additional equipment, but basically the risks there are to the staff providing it. So if all the PPE is there, the risks are to the staff providing it rather than patients. So I want to say that at the outset, because I've given a lot of webinars and patients seem terrified to go to the dentist. We've seen lots of patients coming in and their relatives have been incredibly worried about them coming in. They've been suffering with toothache, so they don't have to come to the dentist. But we have a new risk in dentistry. We've always had a risk from things like TB or airborne transmission, and this is where in dentistry we've got to now move outside of those universal precautions. So whereas we've always taken care of water lines and services with splatter from blood and all that kind of stuff, we now have to realize that in dentistry, when we use
those equipment that spray water, all the things you love that make a noise and spray water everywhere, especially with the hygienist, these throw droplets and aerosols into the environment. And then the sad thing is that the evidence shows they can stay there for up to an hour afterwards. So Laura's been having to do additional work to clean, but the problem is they're there for an hour. So she can't enter the surgery, and we have to wait for all those droplets to come down, and then they settle on the surfaces and she can kill them with her really high concentration chemicals. So there's been this new thing in dentistry that everyone's talking about, which is called aerosol generating procedures. Anything that we do that throws an aerosol into the air becomes an additional risk for staff, but also for the air quality. Now, the problem being that what the evidence shown was that people who are asymptomatic can still transmit. And it's not only when we use our instruments, it's also, we had a lady yesterday who's got a very strong gag reflex. The minute we do anything in her mouth, she coughs and splutters. That straight away is transmitting droplets into the air. So we found in dentistry that we can't always guarantee that our air is going to be is going to be decontaminated. So there, you can see here, just a picture here from somebody who's breathing in and out with saliva, or there's suction going on. You can see those particles coming out into our air quality. So that means during the pandemic, dentists and dental nurses have had to take on this kind of new level of PPE. We've always had gloves, we've always had masks, we've always had goggles, but we've now had to add visors and this on top of that. And this really reminds me of the 80s when I know you can't believe I'm that old, but I trained in the 80s. And when I started dental hospital, I trained with no mask, no goggles, no gloves. We only ever wore gloves if we were doing surgery. So fillings, no gloves. If we were doing difficult surgery, we put gloves on. That's how I was taught. In year 2, during the 60s, the HIV epidemic changed all of that. And during my training, I had to start wearing gloves. And we had all the same things. Dentists are not going to be able to wear gloves. It's going to change the face of dentistry. I can't wear with gloves. I can't. We're seeing exactly the same thing happening now. Gloves have been normalized over the last 20 years. Now, higher levels of PPE, probably forever, are going to be in place for dentistry. Now, this has got cost implications. It's also got supply implications. But for dentistry, it's also got huge implications for communication. Because, as you know, communication is really important for dentistry, for diagnosing, for putting people at ease, for explaining education and all that kind of stuff. That is very difficult to do when you're dressed up like something out of a space station. So I think this is the first thing where I'm going to say that teledentistry and telemedicine will have a part to play, because I'm finding that when I'm dressed up like this, I can feel sorry for myself and I can say, look at me, I'm foggy, you know, I'm sweating and it's hot and it's whatever. But my main problem here is I can't talk to my patients and I can't deliver that anxiety or that reassurance that especially people with bleeding disorders need. Or if you've got questions, it's not really particularly conducive. So that is why I think certainly for the time going forward, both for me and for Laura, because we're both dressed like this to see dental patients at the moment, that teledentistry is going to have such a big thing. So as I've said to you before, this is about air quality, and at the moment Laura is having to leave an hour between appointments to allow those droplets to drop to the surfaces and then deep clean before anybody comes in. So that's again something that we're being able to do our teleconsults during, but we've very gratefully received an order paid for by the Irish Haemophilia Society, which is going to help us address this 1 hour between appointments. So this is a fogging machine. Fogging, and this is one of the new things about what is the new normal. Now, these machines have been used in Asia for a long time. They're kind of de rigueur in Turkey. These are used in waiting rooms and whatever. They've been used in the food industry because they are about air quality. They are about cleaning the air. They haven't taken off in Europe up until now because the chemicals that you have to use to fog an environment are very strong bleaches and things. These are not good for the environment. They're also not good for asthma and things like that. So we've always kept away from them. But we've got revolution really, and Ireland is leading the way here from Dublin Dental Hospital with introducing fogging machines with alternative using ionized water. I'll hand over to Laura to tell you a little bit about what this is going to do and how this will mean that we can get back to seeing patients much quicker. We're looking forward to this arriving later this week, I believe Friday. So Laura, tell us about how it works. I'll hand it to Laura for the science bit.
Great, thank you.
Okay.
So the chemical is called hypochlorous acid, and pretty much it's like table salt and water, and electricity runs through it. And it takes 3 minutes in total to do the whole room. They've done studies in the dental hospital on the drains and stuff where they literally like brand new drains after swabbing them. There's no toxins in it, so pretty much they're actually in a stronger dose. You can use it as a hand sanitizer than what we'll be using it as. And you have to have the window open, which we're glad we have a window in our surgery. And 3 minutes, that's it.
Yeah.
No, the hour is cut out completely.
Yeah. So what will happen is we will be able to fog the environment, and this is where the design of the surgery at Dublin here at the centre has made all the difference. We future-proofed this, and actually we didn't do this so much for you guys. I also provide a service for the bone marrow transplant and the cancer patients who are always immune compromised. So part of the setup of our surgery here is that we have filtered air. Anyway, we've got HEPA filters that are filtering out viruses and things, and that was put in place because I provide a service to the cancer patients who have really, poor immune system. But this is going to, so we are very happy with that, the fact that that was in place. We also had an opening window, because one of the problems in dentistry around the world is that surgeries haven't got open windows, and we have to, at the moment, open windows to be able to clean an environment, and we've got an opening window. So we are hoping, and we can answer questions with the fogging. With the fogger, with the HEPA filters, with the window open, we should now be able to approach our new normal, where we are looking like astronauts, but the environment is safe to provide dentistry. So where are we European-wise? What have we learned? What we've learned is a lot about dentistry from Spain and Italy, because there was no doubt there that dentists died from COVID, because we are such high risk. Actually, the highest risk of all the professions is the dental nurse, followed by the hygienist, followed by the dentist. I'm third in line, but we're all three within the top 5 risks. And what we found was that dentists died. We have dentists and surgeons died in the UK. So if you look on the table here, you can see that Russia is still the top of infections, United Kingdom at the top, and Ireland is doing well. However, where Ireland hasn't done well is that they've had a higher proportion of healthcare providers who have contracted COVID. So whereas our general public is doing well, our healthcare providers in general haven't been well provided for. And this has meant that dentists who are now trying to open up their practices in the community, who haven't got all the stuff that Laura and I've got, have struggled. And so they have got still pretty restricted services. In the UK, they haven't opened at all yet. The dentists, they were forced closed by the government. In Ireland, Ireland's dentists were basically made to just kind of make their own decisions. But there are now clear guidelines for opening up, and this minimum level of PPE needs to be worn by all dentists in the community. So what's the new normal for going to a dentist for those practices that are open? The first one is still the lack of availability of the usual team. We're finding that those who work in the HSC, hospital and university dentists, have been repurposed. A major part of the dental workforce have been repurposed as the tracking and testing team. Because we're used to the mouth, we are a very useful pair of hands for swabbing the throat, for swabbing the nose, because people don't want to go to don't like to do that job. So again, we've been deemed as essential, but that's meant that a lot of the teams who usually provide care for children in the HSC have gone to the swabbing teams. Here at the NCC, we've lost one of our surgeries because of the St. James's being one of the major COVID receiving hospitals. The sickle and thalassemia team didn't have anywhere to go to run their team. So we have repurposed one of our dental chairs, which has become a transfusion service place where the guys with sickle cell and thalassemia have been receiving their transfusions. We have oxygen, we have the windows, we have the filters, a very safe place for them to be able to go. But what that's meant in reality is still we're operating from one surgery only. At the NCC with only myself and Laura. I've lost my team. I don't have my juniors. I don't have my hygienists. So actually it's been nice for us because Laura and I are a good team together, and I've been having to do all of the dentistry, all of the surgery. It reminds me of being back 20 years ago before I had to do such a lot of teaching and mentoring, but we've been cracking on and getting on with the treatment. There has been a limited availability of these aerosol generating procedures during this time because there was lack of clarity about the safety of being able to see patients after aerosols. Having to leave a surgery free for an hour before cleaning meant we could only fit 1 or 2 patients in a day, and with me only working a couple of days a week, that's severely limited. So relying a lot on dental extractions, and that's the same around the country and still is. So lesser availability of appointments. One of the big things about this is the pre-appointment questionnaires. We are still having to try and identify those people who potentially things like, have you been in contact with anybody? Have you shown any symptoms? And on arrival, people need to have the temperatures taken. The other thing which is not so good for people who are coming from abroad, coming from away, or from down the country, or people who are nervous, is attending the surgery alone. We don't want a lot of people in the waiting room. And so for people who are incredibly nervous, or people who are traveling, whatever, then attending for dentistry is difficult alone if you're scared. We've got a new mouth rinse. Laura will be giving you a horrible, thick, sickly brown liquid, which is one of the only things which we know kills viruses. It's povidone iodine. It's the evidence-based only mouthwash to work. And Laura will be making you gargle with it for at least an hour. She enjoys watching that happen. But that means that your throat and mouth is going to reduce any load there.
When can we get in Michael Davenport?
Yeah, Michael Davenport is going to test just how strong and how long we can gargle. We can get people to gargle with. Remember, Michael, it's all about our safety. It's all about us. One of the big things that is really happening is higher costs. Those people who see dentists out in the community, the higher additional personal equipment is being added on to patients to charge. And that is generally working out between 10 and 30 euros per person per appointment. So that is a kind of at cost price, but be prepared that is being passed on. I'll talk a little bit about that afterwards. What we're seeing in the UK and around Europe, we're not seeing in the hospital services in Ireland, is that dentists had this PPE to start with, they've run out, and the supply chain is meaning that now they're having to pay even higher costs for it. So they're closing again, or they're not doing the aerosols because they've run out of PPE. Very importantly, we saw in the news this week that dentists were saying for patients with medical cards who don't pay for treatment, they are not seeing patients with medical cards because they are having to foot the bill themselves for that extra PPE. And before we start slagging dentists, we have to remember that there is a whole 2 teams here that are having to be kitted out, that they already only get paid about 30 to 35 euros to take a tooth out by the government. So you can't expect them to foot the bill for an extra 40 quid's worth of PPE that doesn't foot that bill. And there is most definitely a supply chain shortage for the dentists who opened up. So I think we have to be aware of this, and it's something politically that we should be talking about if patients can't get access to care. So as I say here we go, top of the risks: dental hygienists, dental assistants, and dentists. So dentists and teams out there in the community cannot be putting themselves at risk still if they haven't got the PPE for non-essential treatment. So how are patients coping in the new normal? Dental emergencies are relatively common. What I've been seeing during this pandemic, and what Laura and I have been seeing, is we are seeing patient access to care, or are probably on a webinar like this, are looking after your teeth. And we haven't seen many dental emergencies. However, we've seen people who have never been to the centre. We've identified people with severe haemophilia, with mild haemophilia, who haven't had a medical appointment with the centre for maybe 8 to 10 years. We've been identifying lots of people with platelet disorders, women with low von Willebrands, that the minute that they tell a dentist out there that they've got a bleeding disorder, haven't been able to get care. So we've been seeing a lot of dental emergencies. But what is a dental emergency actually? Because we've realized that the public probably don't know. We've had lots of people asking for emergency scale and polishes, for example. In legislation, a true emergency is something where you've got trauma, where you've got significant infection or pain which can't be managed by medication. So my first question is that one of the things I found is that people with bleeding disorders aren't very good knowing what they can manage dental pain. So the first dental pain medication self-management that we found was paracetamol. People knew they could take paracetamol. They knew they couldn't take ibuprofen. What do you think the second most common pain medication was? Because we've done a survey for self-management. Any takers? Anyone want to guess? Have a guess what the most effective pain management was for people with dentistry, with dental problems?
Arcoxia.
Arcoxia is actually the most effective. I think that was Shay, but people didn't know about it in most cases. People who are very well in touch with information knew, but most thought they couldn't take anything. So the second most common effect medicine in Ireland taken for dental pain is alcohol, is whiskey. We found seriously that people took whiskey mouthwashes. They took whiskey to get drunk, to get rid of the pain, and they also used it as a tincture. And I mean, to be honest, I can laugh, but people were desperate with their dental pain. So I think one of the things we've learned is that patients need to be educated about the same thing that you use for joints can be used for dental pain. We developed, and this is something which is on the IHS website, to tell people how to work with their dentist to deal with one of these true emergencies, because dental pain, we found people couldn't deal with it. They couldn't deal with the living with dental pain for more than 2 or 3 days without it affecting their food, their relationships. And so we very quickly did something which showed patients and dentists how to manage a dental emergency using a traffic light system. If you need an abscess, some questions with did it need draining through a tooth? Did it need lancing? If you need an extraction, to follow an algorithm so people could work with their dentists. And this is where teledentistry came in, because we realized that patients needed mentoring through this algorithm, and so did their dentists. So this is where most of our teledentistry started, and we've taken it very seriously. We've collected data on it. what teledentistry has allowed us to do, and both Laura and I have been carrying out teledentistry, is recognizing that it's nothing new, recognizing that it's something that we've done for a long time. Actually, it's been there since the 60s, since radios were there, but we formalized it, because what teledentistry allows us to do is make a virtual diagnosis. It allows us to ask questions and you to tell us answers to those questions. That allows us to find out what the problem is and identify what needs doing, so that if people are scared to come in or can't go in, straight away we can advocate the proper pain management, move them off paracetamol and alcohol onto Arcoxia, move them off the opioids, which generally don't work for dentistry, on to a good pain management technique. We can electronically prescribe. One of the great things about the Lighthouse was that we have access from home or from the dental hospital to all your records. So what would happen was, if people needed painkillers or antibiotics, then I would prescribe and Laura would fax to chemists so people could immediately get themselves out of pain. General advice, Laura's been at the end of a phone for general advice of people worried with bleeding gums. We've actually mentored people how to put in temporary fillings, but the most useful thing for us has been the assessment of photographs. So if we should be able to move on here. And one of the things that we've done is we've actually now been so pleased with how well people are taking photographs with teledentistry that we've actually started to produce some videos to show people how to take good photographs. So in the past, if people are worried they would take a quick selfie, now we've realized patients can take brilliant photographs. So have a look at this. So this is something which Crumlin have provided for patients of how to actually take a good clinical photo of your child's teeth or your own. The first thing that we need to do when you're taking a photo is find a really bright room. And then if you're doing anything in your mouth, wash your hands really well. Remember that the mouth is a potentially infective site, so are your hands. Look how well these kids wash their hands now. This is the new normal. Look at this, amazing. I wish our medics could wash their hands like these kids have been trained to. Yeah, stunning. Second step, put your fingers inside your cheeks and bite your teeth together. Pull your cheeks out to show your teeth. And the first thing we can do is zoom in and get a really good view of the front teeth. So this parrot was worried about that tooth coming through in the wrong place. So we could reassure her that nothing urgent needed doing, and that appointment could be made at a later stage. Next thing is using a mirror. If you spray a mirror with fairy liquid or with something, it stops it from fogging. And then the small makeup mirror can be used to take pictures inside somebody's mouth. Look at that. We can see right back to the back of the teeth and take a perfect picture of all of the teeth without, so that we can see right back to the tonsils. That's taking the top teeth, and then the lower teeth exactly the same, turning the mirror the other way around, putting their chin up high. There's the bottom teeth. So we can see there's a little hole in that child's teeth, but I can then see there's a massive hole, or if there's nothing much to worry about. Yeah, and then send to the dentist. So we've realized that the new normal now, and here's the Kirsten Fitzgerald from here. So amazing, because what this means is when we see a picture that's of quality, we can then decide whether this is going to be a straightforward extraction, a filling that can be done with your own dentist, whether it's an abscess, or whether it's anything that can be advice only. So teledentistry, if it's going to be quality, means training all of our patients how to take photos of their mouths one-to-one. We're going to produce some of these for adolescents and adults, because we're going to do teledentistry properly. So Because we think that teledentistry is going to help us at the moment in the pandemic, but we think it's going to help us with prevention, providing good dental education, preventing problems happening, perceiving problems happening, preventing bleeding by giving people chance to educate them in how to brush their teeth without them needing to come and sit on a hygienist's chair. And is preventing patients having to come in. If we're reviewing how well a tooth is healed, we can do that remotely. So we've got everyone's jumping onto this bandwagon of saying teledentistry is the way forward. Yes, it's an advice tool. Yes, it can mean we can work at a distance and plan, but still, if patients need invasive treatment, we've got to have the ability to bring them in or provide telementoring to their own patients. So this is where we think that really the message in these videos can be used for patients and played to them or sent to them with exact information specifically targeted for people with bleeding disorders. How to brush your teeth if you're worried about your gums bleeding. How to look after your mouth when you've had a dental extraction. I think all these things we've learned. Svetlana, our hygienist, did the most fantastic study about gum bleeding in von Willebrands. She looked at the beliefs of people with von Willebrands, and we learned that people stopped brushing their teeth because they thought they were doing it too hard, rather than knowing a different technique of how to do it. So I think we've got a great job to pay personalizing stuff. We have put in place, and we've been using it during the pandemic. This is not new normal, but been using it more than ever. We have in the Lighthouse and in the new Universal Records, we have a personalized dental passport, which can be used and requested from anybody. You can request your letter from your hematologist, from the nurse. You can contact Laura's dental nurse, and you can have a letter which says, this patient has a bleeding disorder. It's safe for them to have this, 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 or this. However, should they need this, please contact the NCC, and we can then mentor your dentist using telementoring, or we can give you advice. So you can book a teleconsult for us to advise you if you want to see another dentist, or you can email us. So this dental passport letter, we've been sending them out. I think we've sent 46 out during the pandemic. Laura did a study to show that we have done about 140 teleconsults. We've organised about 45 extractions. We've either done them here or we've done them in the west of the country or the Midlands, mentoring dentists who never would have dreamed of being able to take teeth out on haemophiliacs, but we've been mentoring them through each stage. This has really opened up new channels. So I think the telementoring of dentists is just as important, because everybody with haemophilia should be having a dental home. Just like everyone should have a GP, everyone should have a dental home to go to regularly, but we can't expect those dentists to know everything about haemophilia. And we've got to provide a lifeline for them, for mentoring, but also for you guys if you need advice. And we hope this is where teledentistry will really come forward in the future, both with myself or with Laura or our hygienists. The dental home in the NCC has been identified for, at the moment, our patients over 65, because we are targeting people who are aging with teeth, and also those people who are co-infected. Because we run joint clinics with co-infection, we encourage most people who are co-infected or the late effects of haemophilia to come and see us as the dental home at the NCC, because that is the group, that is it makes it easier for people. And we found in the past that people don't like to disclose their co-infection. Not that that's ever a problem with dentists nowadays, but that's just how we run it. For most others, we like people to have their own dental homes so they can have preventive, regular care. But we provide at the NCC the new normal assistance for all surgical care, or for care where people need factor replacement before they have a procedure done. So Lauren here and I are here now for questions, and we hope you've got some difficult questions for us. So I've just given an outline of how we're running things. From our point of view now, we are running now a backlog of important appointments that were cancelled for people with kind of slightly subacute problems, broken fillings that needed reply, and we are working through them. Once we've got our fogging machine, we are now going to be able to see more like 6 or 7 patients a day or 8 patients a day like we used to, rather than our 3 or 4 maximum at the moment. So that's where we are with appointments. So it's over to you for our questions.